Thank you so much for the invitation, and thank you for having me here. It's a very overwhelming, it's a huge conference, much bigger than what we are used to in Malaysia. So I'm just going to speak about, actually I've loaded up my talk. MANOHARAN SHUNMUGAM. So it's going to be a little bit different from the lasering technique. I know the session is on lasering technique, but it's going to be what happens if the laser fails. So
RP surgeon sitting with us, Professor Parijat. He is at RPC AIMS, and he is doing ROP for more than 15 years.
Right. So perhaps then I'll probably need to ask you for some advice later. Despite adequate ablation, you still get unfavorable structural outcomes in ROP. So the cryo study showed us that they improved outcomes from 51% to 31%, and in the ATROP, the early treatment of ROP, this improved further to only 12% of progression. And this was mainly in the high-risk pre-threshold group at 9%. Conventionally, it was 15.5%. So I just want to discuss a little bit about the indications of ROP surgery. The aim is obviously to salvage anything. You want to go in before you hit the stage 5 ROP, and I'm not going to go through the stages in detail because I'm sure you're all very familiar with it. And you want to prevent progression. And I'm going to focus a little bit on the non-responders in the ATROP group as well. Of course, if you hit it early enough, you'll be able to maintain undistorted macula, which will be the gold standard, of course. So considering all that, you want to be able to intervene between a stage 4A and stage 4B. You don't want the fovea to come off, obviously. Just you got to think about it similarly to a normal retinal detachment in an adult. And of course, you want to try and spare the lens, especially if the macula is attached. And before the fibrovascular proliferation reaches the lens. So you've got to weigh also if you're going to operate the risks of leaving them aphakic versus the risk of getting an iatrogenic break. And nowadays we've got a new tool in our armament, the anti-VEGF, but it's beyond the scope of this talk. I don't have enough time to go into that. Now, just from a pediatric ophthalmology, general ophthalmologist point of view, predicting who will need surgery, it's basically those babies who post-laser, so you've seen that they've got ROP and the indications for laser are there. At post-laser at 2 weeks, if there's any recurrence after regression, or if there's any, especially if there's any ridge elevation of more than 6 clock hours, if there's still plus of more than 2 quadrants, if there's any vitreous haze, which represents fibrovascular organization within the vitreous, and if there's vitreous hemorrhage, then these are all indications for vitreoretinal surgery or surgical intervention in these children. In those who have vitreous hemorrhage, 3/4 of them will have an underlying retinal detachment below that blood. Neovascularization per se is not indicative for surgery, but is surgically a poor prognostic sign for obvious reasons. So the mainstay is still obviously laser. You want to be able to try and control the disease with laser. No one wants to operate in these children. We do still do buckles. 2/3 of them are still vitrectomies. We try and do lens sparing. Of course, if you already have tissue up to the lens, then you might have to do a lensectomy with or without a buckle and with or without anti-VEGFs. So as I mentioned, the surgical goal is to try and maintain an undistorted posterior pole, try and catch it before 4B, much similar to a macula-on retinal detachment you want to get in, try and preserve the lens. But even if it's a stage 4B or stage 5, sometimes even a year after they're found, a lot of patients from rural areas or from Indonesia come to see us, and they've had it for 1 or 2 years. It's still worth trying to do something, because sometimes, and I'll go into that in a little bit, sometimes there are stage 5s and they're very severe stage 5s, and sometimes they do get something. And the aim is to try and relieve traction and prevent ROP progression, and of course retinal reattachment. So the surgical approach obviously depends on the extent. 4A is a very wide range. You've got very mild 4As, which is only 1 or 2 clock hours, but then there are some that are 5, 6, 7 clock hours. So you can consider a lens-sparing vitrectomy or buccal. Most of them lens-sparing vitrectomy sometimes. And that shows in a study by Hartnett that with the lens-sparing vitrectomy, you get less ROP progression, and that adding on a buccal sometimes doesn't improve outcomes. So as I mentioned, a small 4A scleral buccal may be indicated, especially with very localized peripheral RD. And of course, in these children, they've got other comorbidities as well. So you want to avoid repeated GA. So immediate sequential bilateral surgery is an indication. And the one thing that the picture I put up here is to ensure that you've got a good pediatric anesthetist who knows what they're doing, and that makes a huge difference. As you can see, one of the tips from our anesthetist is that you keep the baby warm. So they wrap them up like a mummy, and they wake up immediately. There's no trouble with the anesthesia. Of course, the fellow eye has a similar threat. You have to beware of infections, but you have to weigh up the risk of progression of not doing anything and these children not being fit for a GA subsequently over the risk of getting a bilateral endophthalmitis. So the surgical technique is generally we go through the pars plicata, ensure that there are no lens or ciliary body attachments before you go in, of course. Do a core vitrectomy, relieve the vector forces. You don't induce a PVD in these cases, and then just a fluid air exchange. There's no need, if there's no break, there's no need for an internal subretinal fluid drainage. And this SRF, just be aware that it can take months sometimes to go away. But if there's no break, then it does go away. So the surgical anatomy is very different. If you look at it, these three all look the same, but the pathophysiology of the detachment can be very different. So you have to remember that inside the eyeball, the vitreous is a three-dimensional structure, and there are many vector forces which you need to address. One is intrinsic to the retina, where you get the circumferential vector, which causes these radial folds, and might be amenable to a buccal if it's very anterior and localized. And then there are these ridge to lens, as you can see here, which are attachments to the mid-peripheral lens. You have to incise these ridge to ridge across the mouth, the picture at the bottom. Ridge to ciliary body and ridge to retina. The ridge to retina, sometimes there's intraretinal as well, which is very difficult to address. And the disc stalk as well, sometimes adherent, very adherent, which you need to incise, but just make sure you don't incise the retina, which can be pulled up into the stalk as well. And then, as I mentioned, in the stage 5, there are stage 5s which are very severe, and there are stage 5s which they call minimally fibrotic. These tend to do a little bit better. So it's minimally fibrotic if you can see that there's this retrolental membrane which is a bit more translucent, and you can see the underlying retina. And the absence of anteriorly rotated ciliary processes. So you know that these children do a little bit better. And this is one such case where you can see there is the retina coming up there, and B-scan shows you a total detachment. And this child, I think, was about more than a year old. So it's still worth doing the op. So I went in bimanually and just dissected off the membranes, and you can see the retina right there. And if you can manage to get, like I said, try and relieve as many vector forces as possible. So first you incise the membrane, and if you can, I think I'm missing a picture. If you can get it, then it's, this is that same child after a few months actually. So it can come back. However, you can see the posterior aspect of the retina is still attached. So this is worth, I don't know, and I would get advice from our co-instructors whether it's worth going in again to do this after a recurrence. And maybe that's something that we can discuss in a bit, as I'm running out of time. So post-operatively, we maintain a prone position, atropinize if there's unilateral aphakia. Just always remember to visually rehabilitate this child, and I work very closely with our pediatric ophthalmologist. And these are the things that we would advise the parents to do. Of course, don't forget the other things because they have other comorbidities. These are very well-known statistics. I'm not going to dwell on them, but obviously the ones with stage 5 don't do as well as those with stage 4A and 4B. Now, the very high rate of complications, up to 50% of iatrogenic breaks, and if you get a break, then there's almost a certainty of failure. Cataract, endophthalmitis, apneic spells is one thing to watch out for. So why would we do this? Sure. There's late sequelae of myopia, glaucoma, macular heterotropia, retinal breaks. So why operate at all? Well, it makes a huge difference to that child. It preserves the optic nerve for perhaps some future therapy, and it's one of the best cost per quality of associated life years improvements that you can give as a society, as socioeconomically, versus the cost of certain blindness to these children, which is 6%. And you can see here, laser for ROP and cryotherapy for ROP is one of the cheapest things that we can do because it gives them a huge amount of quality of life years, as opposed to treatment for central retinal artery occlusion, which you can see is about $3.9 million because it hardly works, but everyone likes to talk about that. Very few people talk about laser. But I'll just wrap up by saying prevention is always best, and you want to laser these children, and the study by Anna Els shows us that if you just extend the laser a little bit posterior to the ridge, you reduce the rate of progression from 6% to 2%. So I would especially since there's a course on laser, I would advise that you laser a little bit further to the ridge, and especially in cases of AP-ROP, you need to be aware there are these avascular zones and laser that as well. Just because you see a large vessel there, it doesn't mean that the retina is fully vascularized. And I think I'll just finish there by saying that I'd like to invite you for the APAO, which is in Kuala Lumpur next year, 2021. I hope to see you there, and I'm sure the coronavirus will be gone by then. Thank you.